question, what is therapeutic drift? I think when a therapy is used in a way that exceeds the available data. If it's good, it must be very good, and we can expand its use. And that can be a little hazardous. You can make mistakes on the way. One is the use of caffeine to babies to stimulate breathing. And it was shown that if they have apnea or pauses in their breathing, these are relieved and they actually do better longer term. So now it's being given almost in the delivery room to some of these little guys. So what's happened is we're giving it earlier, we're giving it longer. That's probably okay, but we're now giving bigger doses, and that spooks me out a little bit because the pharmacology, the pharmacokinetics of caffeine are complicated. Different cellular mechanisms are involved depending on dosage, at least in animals. We don't have data in babies. There's some data that maybe brain hemorrhage could be a problem with an excessive dose. People justify giving it earlier because data suggest when it was given in retrospective reviews, when it was given earlier, the outcomes were better, which is true. But maybe it was given earlier to those babies who were destined to do better to begin with. And the way to deal with that is to do a prospective study where you randomize babies to early versus late, and none of that has been done. The detrimental implications of therapeutic drift are you are using a drug unnecessarily, and that drug or a therapy has safety implications. I think that's the main issue. And the other thing is, of course, when you're dealing with particularly premature babies, we worry a lot about their longer-term outcome. We send the babies home. Most babies do well. But we need to follow these babies into school age and beyond. And that's difficult to do. And I'd hate to think that we discover we've done some bad thing by giving too much of a dose or the wrong dose, discover it when these kids are 10 years old. Any potential detrimental implications may not become apparent, right, into childhood, which requires a few things, right? It requires time. It requires those babies to be followed up. And we are not always as good as we could be about bringing babies back. Follow-up studies which look at the longer-term outcome of our interventions really require that you get about 85-90% of these babies back. If you only get half of the cohort back, you don't know whether you're getting the good ones, the bad ones. It invalidates data. So I think it's a special problem in preemies because the implications may be much longer term at that stage of development. So I think it behoves physicians and caregivers, really, not just physicians, right? Because so much of what we do is nurse practitioners and hospitalists and physician assistants to keep up with the literature. And I think practice will change. And there's some things, I guess you can't be too rigid, you know, and that's what I was saying, coming back to the caffeine story, which is how this began. So you give it a bit earlier, maybe that's okay. You give it a bit later, that's okay. But mess with the dose, and that's tricky. So I don't think you have to be totally rigid in how you employ therapies, but I also think you have to be cautious. One of the things that I sort of alluded to earlier is how therapeutic intervention can become preventive intervention, and that's tricky. Just because you can treat a disorder successfully with a medication doesn't necessarily mean you can prevent that sort of thing. And I think, and the reverse can happen too. It sort of reminds me of the COVID situation we live in where people are being hospitalized or unvaccinated, and then they want an immunization because they think it's going to help. Well, prevention doesn't necessarily work as therapy, and conversely, therapy doesn't necessarily work as prevention.